involvement. In contrast to this focal choroidal involvement, here is a diffuse choroidal involvement. You are right, this is only VKH. So additionally, combination we will see here, vitreous reaction is absent in CV retinitis. It has to be absent because they are immunologically deprived. So it has to be absent. Whereas ARN patient will have 4 plus vitreous cells. If you see this absence of vitreous cells and retinitis, it is only HIV and CV retinitis. When you have 4 plus vitreous cells with retinitis, it is only ARN. Even in HIV patient, ARN will have vitreous cells. So this vitreous reaction is so important and it further confirms your diagnosis. Then comes your optic disc. The optic disc is usually pale at the end of ARN. Optic disc is edematous always in BKH. Till the inflammation gets subsided, it is always edematous. So you know that all these findings help each other and then it give you an etiological diagnosis. So now, have you spent any money for this 4 diagnosis? We have just seen the clinical signs and we have not even talked with the patient. All these 4, only with the pattern, you know the diagnosis and you will confirm with your lab diagnosis. In this slide, we are going to see what are all the parameters we need. You will agree with me, in the previous 4 examples, we have not spent even 1 rupee to make the diagnosis. We have just seen the clinical signs and associated signs and we made the diagnosis. Here we will have a play. We will change the gender in one slide, we will change the systemic association in one slide, and we will change the fundus examination in another slide, and you will be giving the diagnosis. I will not do anything. And we will go back to our original case with the diagnosis. And this is a 55-year-old famous lady with VKH. She had headache, she had bilateral acute loss of vision, and she had ultrasound thickened uvea, and she had uveal thickening with X-ray TWRD, and you made a diagnosis as VKH. Now I am going to change a few of the parameters with same age group. 55-year-old lady with chronic. The previous one was acute loss of vision. I was repeatedly telling you acute loss of vision. Here she has bilateral loss of vision, but it is chronic, and bilateral panuveitis like previous lady, but it was not X-ray TWRD, or it is not choroidal thickening, it is not FFA leak, it is high ACE and hilar lymphadenopathy. In X-ray, you have beautiful hilar lymphadenopathy. You tell the diagnosis, yes, it is only sarcoid. You have all, I have just made a few changes. Acute, I changed with chronic, that's all. And ACE and hilar lymphadenopathy, also, I have changed with lab diagnosis. And the diagnosis totally differs. Same 55-year-old lady here. Now we will see one another 55-year-old lady, not with headache. The first lady had headache, this lady has eye ache and retinal necrotic patches. It is little difference. And vitreous cells, VKH did not have vitreous cells. Sarcoid had few vitreous cells, but this has lot of vitreous cells, 4 plus vitreous cells, and vasculitis, and retinitis. And you know the diagnosis. You are right, this is ARN. This is only ARN. The same 55-year-old lady, few things change and your diagnosis changes. Isn't it an interesting game? Now we will change the age. 35-year-old truck driver. Okay, the moment I say truck driver, my nurse used to tell the diagnosis. It is wrong, it's not right, but still, with the truck drivers, you know some diseases are more common. And he gives history of exposure. He is FDA ABS positive and his fundus shows multifocal retinitis. You know that it is syphilis. Wonderful, no? There are few changes. And here you cannot say a 90-year-old lady FDA ABS positive. In old age, FDA ABS will be false positive. So you will not make a diagnosis there. You'll be very cautious. Okay? Now I will give you a wonderful example of a young girl. She's so sad. She's suffering. We can understand from her emotion. And her eye is, it looks like she had an injury there, or maybe my referring doctor told that it is a flicton. And many times my students also say that it is flicton. And maybe infectious, it looks infectious. And she has a lot of pain, not only eye pain, probably she has a lot of systemic problem also. That's why she's so sad. And now I examine her. I'm not convinced that she has flicton. So I want to see why she's so sad. I have started examining her from top to bottom. And she has a mouth ulcer, big mouth ulcer. And her hands are looking very funny. This hand is not 12-year-old hand. Its skin is so tight. It's like 60-year-old skin, very tough. It is not soft like a flower of a 12-year-old girl. And her lab investigation is not telling anything to us. CBC normal, MANTO normal, XHS normal, VDR negative. It is not telling us anything. But you know what? Tough skin is there only in scleroderma. Scleroderma is a killing disease. And treatment is started. See how she has improved. And that helped us, that lab test that helped us to reach the diagnosis of scleroderma is ESR was 70 and ANA was positive. Only because of that, I thought it should be scleroderma. And that supports this picture. High ESR, ANA positive, tough skin, only scleroderma. But surprisingly, ANA specific for scleroderma has low sensitivity and low specificity. Sometimes it has only 40%. See, this particular test is only 40% of the patient it can pick up. But your history and repeated ANAs, you have to do repeated ANAs. High ESR, high CRP will tell you the diagnosis. We started the right treatment. See how beautiful she is after the treatment. And you have not only saved her vision, you have saved her life. Because scleroderma can cause esophageal stricture and after some time she cannot swallow anything. So immunosuppressive treatment is so important. Now I am going to show you a picture which everybody will shout with the diagnosis. A focal retinitis with a healed cornea. You don't need anybody's help. This is only toxoplasmosis. The moment you see the fundus, it is toxoplasmosis. Vitreous cells are there, it is toxoplasmosis. Now I will show you a beautiful picture. What is this? When you see apple in your hand, nobody needs to say that it is apple. You know that. Apple looks like this. And this apple you have learned from LKG. So nobody need to be there to recognize an apple. But imagine, I am having a microscope here. I have put the apple in the microscope. I have covered everything. I am asking you to see through the eyepiece of the microscope. What will you see? You will see something red. That's all. Will you recognize an apple under a microscope? You will not recognize. You imagine you will enjoy that picture. You will be looking at there and something red is there. you recognize. You tell me the name. Oh, I can't. Something red is there. I do not know what it is. Even if you magnify, only red will get magnified. Okay. We are not going to have Hubble's telescope at all in the near vicinity, but just imagine that you are seeing the same apple with Hubble telescope. And this instrument cannot make you recognize an apple as apple. Why I am telling this example is, there are some diseases so obvious with clinical sign, but we will be ordering RT-PCR, we will be ordering MRI brain, we will be ordering CT scan, we will be ordering so many tests, it will only confuse you. Some diseases has to be seen with simple eyes. Then you know the diagnosis. You will recognize better. So unnecessary diagnosis, doing all diagnosis will give you too many false positive, too many false negatives. You have to be careful with that. This is a very, very important slide. You imagine you will enjoy that. Now, for the assessment, I will ask you a few questions. I will not tell you the answer. Name few symptoms of uveitis. And very, very simple question, isn't it? I'll tell you the answer. Red eye, pain, photophobia, defective vision. This can be there in glaucoma also. But I have asked few symptoms, not specific one symptom. Photophobia probably is more specific, but still that can also be seen in glaucoma. Few signs of uveitis. You know pretty well. It's very, very easy. It is circumciliary congestion, AC cells, flare vitreous cells. They are more specific than symptoms. The signs are more specific. You know it is only uveitis, nothing else. 2 signs of decay syndrome. You've seen that 55-year-old lady. You remember it so well. I have repeated so many times. X-ray retinal detachment and disc hyperemia. What is anatomical classification of HLB27 uveitis? I have explained to you with another example, and I have shown you a beautiful, perfect fundus. So you know that it is anterior uveitis. Name 2 signs of ARN. ARN I have shown you 2 or 3 times. You know ARN. 2 signs I have repeatedly told you. Tongue-shaped retinitis and intense vitreous reaction. 4 plus vitreous cells. So these are all the things. With few symptoms, history, signs, you can make a diagnosis, clinical diagnosis. You can pass your exam with first grade. You will agree with me. So students, I hope this session was useful to you. Thank you.